welcome to this very special series of robotic cardiac surgical videos brought to you by the amazing Dr. Faris Khalil. He works at the King Faisal Specialist Hospital and he's done over 500 robotic cardiac operations, including some of the most difficult you'll ever see. Yes, he was the world's first to do robotic heart transplant. He's done a robotic LVAD, BIVAD, triple valve replacement, and much more. So this is a whole big series of robotic cardiac surgery training, and I was lucky enough to go to the King Faisal Hospital to see these amazing procedures. So we've actually got lots of videos for you. Let's get stuck into this one. Of note, we've got the long version of this and a quick one on CTSNet. So hope you enjoy this video in collaboration with CTSNet.
So today we're doing a 52-year-old lady who comes with dyspnea class 3 out of 4, palpitation, and no chest pain or syncope. So she doesn't have previous medical illness. She had an echocardiography showed good LV function, RV function. However, there is severe mitral regurgitation that was discovered by echocardiography to have a bileaflet mitral prolapse, A1, A2, P1, and P2. So with this overshooting of the mitral valve has caused her severity of the regurgitation. Nevertheless, there is also severe dilatation of left atrium. In ECG and Holter, she has a lot of ectopics and SVTs, nevertheless no recorded atrial fibrillation, but that was 24 hours Holter. So in this situation we do ligate the left atrial appendage, we do perform left atrial maze procedure via cryoablation, and we will repair the mitral valve. So it's a complex anterior mitral and posterior mitral prolapse where she has to receive around 6 neocords between the anterior and posterior leaflets. The height of the posterior leaflet neocord is going to be around 1.5. The anterior leaflet neocord is going to be around 1.9. Then a band of semi-plasmatronic, most probably. Any band a flexible band can do. And the size of the valve is around 4. So the band might be the size of the anterior mitral leaflet, which was measured here at 2.6. So we will put it 2.8. We oversize more than undersize to avoid SAM, of course.
Yeah, and of course, you're doing it robotically. This is maybe your 520th case here at King Faisal.
Correct.
We hardly even mentioned that it's robotic. This is your routine, isn't it?
It is. As a matter of fact, all comers to our MDT, they go for robotics unless there is any sort of contraindication for that matter. But of course, yes, she's going to go robotic for this case today.
Amazing. Let's do it.
Yes, let's go. There you go.
Okay, so mitral valve, both the leaflet are prolapsing. The anterior mitral leaflet is prolapsing more than the posterior one. The chordae are not that much elongated, but this we will see better in the transgastric view.
You said that there are thickening of the mitral valve.
Yes, the mitral valve is thickened and there is bileaflet prolapse, both of the anterior and of the posterior mitral leaflet. Now, coming to the papillary muscle, I was telling you that the anterior papilla is thickened and also the chordae are thickened and are shorter.
So thank you very much for that introduction. So I'm going to talk you through the operation. So first of all, Faris is helping Adele, the consultant anaesthetist, with the SVC line through the right internal jugular vein. And this then gets connected up to the circuit. So there is the SVC catheter and he will connect it up. And then after that, Adele is going to insert a central line that he'd previously put a wire in for. So there goes the central line. So all done in the operative field, but by the anaesthetist and the surgeon. Now the surgeon is going to plan his incisions. He's done a series of marking. The port for the utility incision is going to be at the 4th space, so he's marked that centrally so he knows where the 4th space is, and then we're going to show you all the other ports as well. So first of all, the access incision, it's about 3 to 4 centimeters in size, and it needs to be that size because otherwise you're not going to fit a valve in. So this is a extra small Alexis. Then this is the third arm. This is going going to be the left atrial retractor. Very importantly, that port is then going through the fourth space, the same space as the axis incision. Then this is the right arm port. This is at the sixth intercostal space, quite posteriorly and as low down as you can, just above the diaphragm, so that you don't get clashing as much space as possible. This is now a tiny stab incision for the sump sucker, and Ferris just feeds that in and tucks it out the way. That'll be used during the operation. And then finally, the left arm is second intercostal space, and basically just to the side of your uterine incision. That's the port setup for this robotic mitral valve replacement. Now, just talk about femoral cannulation. Firstly, they do an antegrade catheter for antegrade plegia down the leg during bypass. Then they're going to feed in a wire under TOE guidance for the femoral arterial cannula. They're watching the screen, they're watching the TOE to make sure the wire is all the way up to the descending aorta. They like to go really high up with this. So this is the femoral arterial catheter. This is now clamped and connected up to the circuit. Of course, just look at this little side arm. So this little side arm goes to this antegrade perfusion catheter so that the leg doesn't get any malperfusion during the bypass or even DVTs or thrombosis from swelling. It's a really nice tip. They always do this. So there's the arterial line connected up to the bypass circuit, and we've got the SVC circuit, the aortic cannula. Now we just need the IVC venous cannula. Again, this is done under TOE guidance, and very importantly, Ferris really likes this IVC cannula to go all the way across the right atrium into the SVC. He's quite particular about this. You can see him actually pushing it a little bit further because that's really important for decompressing the right atrium, so he gets a good view in all his robotic operations, especially aortic. So now we're going to dock the robots. Of course, this is the most exciting bit for most of us, but it's routine for the team in King Faisal Hospital. They do this all the time, so they just take it in their stride.
Stop. Go back towards you a bit. Stop. Go down to the foot. Stop. Perfect. Okay, now you go on pump.
So we're going on bypass, and Ferris is going to set up the robot. First of all, the cannula for the camera. He puts this through the access incision. He's then going to connect up the camera and then put in all the other ports.
Now I'm close to the robot.
Very good. So we do targeting, which just straightens up the arms and makes sure everything is as spaced as possible. And now he's inserting the left atrial retractor and his instruments ready to get going for his operation. And off he goes to the console. So we join him here now on the console. We've got two views, so I'm going to show you also what the assistant does, as it's a really important job. So he's starting with scissors in his right hand and DeBakey forceps in his left. So first of all, we're just going to open up the pericardium widely. He finds some adhesions, but of course this scissors has got molopona cautery as well, so that's dealt with very easily. And then he incises the pericardium all the way down to the diaphragm. So he's got lots of vision, and you can see the left atrial retractor just at the top. That's his third arm, and he's going to sneak that in. Now watch as the assistant is going to pass in the needles, because he's now going to do 4 pericardial stay sutures. But the assistant's really important. He's got to have good VAT skills. He's going to pass the needles in and take them out, and he's going to clip them to the side once this has been done. So actually having a really good assistant is phenomenally important. They need to be very experienced, possibly even able to do the operation themselves, or consultant level, or experienced physician's assistant level, and that's again why we've got the view from outside as well. So that's 2 of the pericardial stays. We're going to do 4, and you can see very easily that it's a really good dance between the assistant and the surgeon, putting in the sutures, and these are plegited, and actually these are going to be used to close the pericardium at the end as well. So they do 2 jobs, retracting really nicely for the case, and they'll close the pericardium at the end. So that's the 4 pericardial stay stitches all done. And now we can go and attend to the heart. So first of all, we need to do the cardioplegia cannula. So Ferris does this exactly the same as you do an open cardioplegia cannula. It is exactly an open cannula. So he's going to do 2 horizontal mattress sutures, one going with the sutures from the top and the other from the bottom, and these are plegited. And of course, he's going to use these to close the hole at the end of the case, and he will do that by the bedside at the end of the case. So that's the first purse string. Here's the second purse string. Again, passing in all the needles by the assistant, and then Ferris doing it robotically from inside with the large needle holders. So there's the 2 stay sutures in, and then watch as the assistant has to pass in a standard cardioplegia cannula, and then Ferris can take control of it. They're kind of holding it together, but Ferris has got control of exactly where it's going to go, so he knows it's precisely to the millimeter right within his stay sutures, and then he can push that into the aorta, and then just like you do open, you're then going to put those stay sutures nicely to hold this cannula in. So there he goes, just putting the stay sutures in nicely, and then the assistant's going to snug these down, and we've got a beautiful safe cardioplegia cannula, which obviously will act as a vent as well, and we can snug these down at the end. For hemostasis at the end of the operation. So that's that. So now we're going to get the Chitwood cross clamp. Again, let's watch the outside view as well as the inside. The assistant is there ready to close, and he's got control of where it's going to be placed on the aorta, but he's also going to use a sucker to push the aortic root down, and they can actually see the left atrial appendage, and so you can actually watch and check that you're right across the aorta. So the flow's down, the cross clamp's up, on, and the flow can go back up. And then just watch bottom left as the assistant can then tuck this Chitwood clamp away really nicely out of the way. Ferris has a Tile Pro, so he can see the observations. You could see he was just checking that we got asystole with the cardioplegia, and now we can open up the left atrium in Sondergaard's groove. So remember, we've got that sump sucker in, and also his assistant has got a second sucker available. So we go into the left atrium and just decompress it. He doesn't routinely use snuggers around the SVC and IVC when he's going only on the left, although of course he would if he was going on the right for a tricuspid, for example. So now using the intuitive scissors, he's going to open the left atrium widely, and he really likes to just open up that space just between the pericardium and the border of the heart just here. He likes to be able to see the fresh air there, because we're going to actually do a maze, and so he's going to need to do a freeze down to the coronary sinus. So now we're going to get an absolutely beautiful view of the mitral. So let's hand over to Ferris Khalil, and he'll take us through how he's going to assess this valve for whether it can be repaired or needs to be replaced.
Look at this, guys. So it's exactly what the echo is telling us. Look at the cords. So Dr. Dunning, you see the cords? They're very shortened. They're fan looking. There is fusion in the lateral commissure, and look how it looks like parachute. This is the first sign of failure of repair should you repair. The second sign, so the first sign is the parachute. This second is the fusion here. The third is the shortage of the cords. The fourth is the thickened papillary muscle. The valve here is thickened, as you see. We always look, it has to be less than a third of the valve. So this thickening is almost a third, but I would still repair it if the other 4 modalities wasn't there. Like, look at this commissure. Look, this medial commissure looks beautiful. So this is beautiful commissure here. This transparency of the leaflet, it's excellent. This is how a mitral valve should look like in this side. However, this is not how it should look like. This is some sort of rheumatic changes happening to the patient. Look at this. This is not a normal mitral valve. in addition to the parachuting area. Look how thick is the anterior lateral muscle. This is also thickened, but the shortage of the chordae, look how short. This is not good. Look, almost the papillary muscle is almost touching the mitral and leaflet. This is 8 millimeter. Okay, so if I want to measure, look, it's even less than 8 millimeter. The normal heights of a valve posterior is around 1.2 and anterior 1.9. Not 1.2, even 1.4 and 1.9. So 8 millimeter, that tells you this is shortened. Even the there is a cleft, as you see here. There is a cleft in the valve as well. This is not a normal valve. And look at the anterior, the A1, the P1. The P1 scallop is massive. P1 should end here. This area should be P1. And this area should be P2. But look, this is an anomaly in the valve. This is P2. And where is P3? This is P3. P3, P2. So there is an anomaly in the valve. You see how it looks. It's split in the middle of P2. Even more than a middle, because that's the A2 here. And look, it's passing the cross. So towards more P2. This is an anomalous valve. Guys, do you vote for replacement? You agree with me, Faisal, right? Yeah, this is not a normal valve. It's sad that we're going to replace, but it's better durability. So I need the open, please, Onyx mitral sizer. Are you still giving cardio?
Yes.
Awesome. So, Dr. Dunning, we use the time while we're giving cardio. You can see if I press here on the root, there is custodial coming back. Did you give 1500?
1700.
Khalas, you can stop if you want.
Okay.
Thank you. And I'm going to take the valve out, and Dr. Dunning, you can look at it once I take the valve out. To see, even I'm going to take a chunk of the papillary muscle so you can see. I'm going to take this chunk. I'm going to put a mechanical valve. She's 52 and with atrial fibrillation query history, not proven. So of course, when shortened leaflet, you don't want to keep the papillary muscle with shortened chordae N, because that will interact with the mechanical struts. However, we always keep part of the posterior leaflet attached to the papillary muscle in order to prevent left ventricular modeling. Not yet, I haven't cut it out, but soon, Dr. Khan. Thank you. So, yeah, Dr. Dunning, you can have a look at the leaflet as well to see how terrible it is. So, see this, Dr. Dunning? I will keep the sort of A1, A2 split with this shorted, and then I will tuck it with my sutures into the mitral annulus to reinforce it. And A3, which is this area, is still attached, and also that's a commissure, and this is A3. Sorry, P3 and the commissure. So we're good. Can I have the needle holder? I'm gonna close the left atrial appendage, then I'm gonna do maze, then I'm gonna replace the mitral valve.
So great explanation there. So we're now going to proceed with the operation, and Ferris always likes to occlude the left atrial appendage, especially if there's a history of paroxysmal arrhythmias, as in this case. So he does multiple layers. He likes to do at least 2 layers. For brevity, we've shortened this a little bit. Of note, just remember, we're also providing the absolute full video, 1 hour 40, with Ferris describing it completely for people who really, really want to get into the weeds of exactly how to do a robotic mitral replacement. So do check that out on CTSNet. But here you can see him doing multiple layers of suturing to make sure he's absolutely, completely occluding the left atrial appendage. And you get a really good view as well of the assistant, how important the assistant is in following the suture. Needs to have really good VAT skills. And of course, the assistant is going to tie the knot as well. Not everything can have a core knot, so these need to be tied properly with a chitwad knot pusher. And then the assistant, of course, has to also cut that suture. So now we've done the left atrial appendage, it's time to do a maze. So they've got the AtriCure Cryo Ice probe, and first of all they're going to do the inferior freeze. You need to go from the left atrial appendage. You need the left atrium to be stretched so there's no ruffles, and it's a nice straight line going all the way across the inferior border to our incision. So that's going to do half of the encircling of the pulmonary veins. It's also going to the left atrial appendage, and that's nice. So that's the inferior freeze done. So now we're going to do the upper freeze to complete this pulmonary vein isolation. The assistance obviously very important in rotating the probe and then getting it positioned really nicely. And now Ferris is just making sure there's no folds in the left atrium, and now gets it freezing. And again, you can see we're on the left atrial appendage, and we're connecting right up to our incision line. So that completes the pulmonary vein isolation. And he also does a coronary sinus freeze that goes all the way up to the mitral annulus, and that's why he had this slightly bigger incision at the bottom here and got into free air below, which is really important, preparing for this. And that is the coronary sinus freeze. So that's his left atrial maze done. Now it's time to do the mitral valve replacement. So this is going to be a series of horizontal mattress pleated sutures, and he's going to, as he just showed there, just hold it about halfway on the needle, quite near the front really, for better maneuverability. They are quite large needles. And we're going to do a line of horizontal mattress with the assistant remove them at each stage, and each one is pleated. And we're literally just going to go all the way around anti-clockwise. The really great thing about robotic surgery is just the view of exactly where to place all sutures. I'm sure you will agree is absolutely stunning. You can see exactly where the annulus is. Of course, as we come around here, we've got to be careful of the circumflex coronary artery, and which is just coming up here or in a suture or two's time. So you really get such a good view. Also, it's quite quick to place the sutures with a good assistant that's just passing them in all the time. You know, it's not slower robotically, it's probably as quick, or even perhaps you could argue slightly quicker. And of course the vision and view is so good that you can place your sutures absolutely perfectly. Look, that's right on the annulus. Of note, he's left, as he said, some posterior mitral valve leaflet here. So he's just inverting it with these sutures, and there are some secondary cords to preserve the left ventricular geometry in the long term. Because remember, this lady is in her early 50s, and so this valve's got to last a long time. And so we're just going along the posterior mitral valve leaflet, placing each suture perfectly. And obviously alternating colours. And while we're doing that, the assistant is ordering them all nicely on the outside, exactly as you do for an open operation in suture hold with a suture holder, so that he's then planning to be putting them into the valve when that time comes. Now look at this. He's stitching with his left hand, so the robot allows you to be ambidextrous. So he's got a DeBakey grasper, but actually it works really nicely for holding the needles. These shots work much better from the left hand. Of course, the robot's got a tremor filter, and it's just really easy to suture with your left hand and your right. Of course, people practice quite a lot on the simulator, but it's easier than you think to be able to change hands to go ambidextrous. So everybody's ambidextrous in the world of robots. And look at that, what a beautiful view, facilitated by the robot and the left atrial retractor. We're just coming along the top of where the anterior mitral leaflet was. And at about this point, we size up. This is just a standard open sizer. So Ferris hates this, to be honest, but it works. So he's sized up, and then they're getting the mitral valve ready as we just come and do the last few sutures. So you can see him quickly placing these in, just two whizzing in there super quick. And as we come along to do the last 3 or so sutures. And then after we've done that, then actually the assistant is going to be placing all these sutures into the mitral valve. Because obviously that's going to be done outside the patient prior to it being placed into the chest. So just a couple more sutures left. Again, just absolutely millimeter perfect. Remember, this area has got the aortic valve much closer than you think. Plenty of people have snugged or snicked an aortic valve non-coronary cusp at this point. It is much closer than you think. So it's really important to get these last few stitches totally perfect in this area. But as you can see, we've got a view into the ventricle. Really nice job. And now we're ready to just put these sutures onto the valve. So this is done by our 2 fabulous bedside assistant surgeons. You can see the suture holders here. So it's all in a nice order. I believe we did about 17 sutures in all for this quite large valve. And so the assistants are now just going to place this into this valve. This is an onyx valve. Ferris really likes the onyx valve, which can take slightly lower anticoagulation INRs, which is great to reduce the chance of postoperative bleeding in the next 50 years of this 50-year-old lady's life. And so that's the first set of sutures done. And then we'll flick that over and do our second 3 set of sutures. And of course, Ferris gets to chill out, relax a bit. He actually comes to the table and watches and has a chat to the anaesthetist, checks that the perfusionist is happy. So actually, this is it's a good, useful time just to have a little bit of a chill and a relax. And he finds that the operative times are roughly similar to his open operations, really. The cannulation time probably is longer than an open case, but the actual procedure times aren't really particularly longer, which is great. Because that's super important, and you have to get your learning curve down so that you don't have prolonged bypass times when you are learning robotic surgery. So just the last line of sutures here before we're ready to get this valve into the chest. And of note, these valves are pretty decent chunky size, so hopefully it will fit in our hole. The hole's been made only just the right size to fit a valve and nothing more. And so here we go, we can have a little go. Well, it's not fitting on its housing. It's too big to do it on the housing, so Ferris suggests that the bedside assistants just take this off the housing, which they do, so that it can then try and push it in sideways to just squeeze this in. So there they go, just fits through his incision. That's a great tribute to Ferris, that literally the size of the incisions are limited not by his abilities robotically, but simply by the hardware of needing to do a mitral replacement. So initially the assistant pushes it in, but then Ferris will take over with the robotic arms, and then the assistant will be able to tighten the sutures to get this laid down really nicely. So here's Ferris taking over, instructing the bedside assistant to pull tight on the sutures. You can actually see the pledgets underneath. We can see that there aren't too many loops around at all, and they're all just getting tightened. And now we're ready to use the wonderful core knot. So Ferris helps select the 2 sutures, and then the bedside assistant pulls them out, loads up the core knot, and we simply fire the core knot for every single suture, which is great. Obviously, this is an important job for the assistant. They're the person doing the correct tension. They're the person making sure that they don't pull too tight to pull it through, and they don't leave it too loose. And obviously, really importantly, you can see together the assistant works with a nerve hook, and the robotic surgeon is selecting the sutures and making sure they don't get tangled. You can see Ferris's right hand there pushing the other sutures out the way, so he's got a clear view and selecting the next one for the core knot. So we get round very nicely. Obviously, they can be done in any order, and Ferris likes to do it in this order: anterior first, then some posterior ones to get it all snugged down with the valve open. As you can see, we're making sure there's no pledgets that are proud or could possibly get in the way of the leaflets. So last few to tie down now, nearly there, and that is our beautiful valve in place, pretty much ready to finish. And that was the mitral valve replacement. So, of course, after we've done these last few core knots, we need to test the valve to check there's good mobility. So Ferris can do this from the console, and they're opening and closing really nicely. And also the bedside assistant can use a plastic instrument to just sort of make sure it opens and closes as well. But you can see that's working perfectly. Great job done. Left atrial appendage is closed. Maze is done. And now it's just simply time to close the left atrium. This is done really nicely and quickly. Of note, this suture, you will just see, has got a knot on the other end. So the assistant takes it out, threads it through the little tiny eyelet, and there you go. That's knot tied without having to tie a knot. It's got a little pledget on it as well. And now simply we can do the layer of left atrial sutures. And again, the assistant's absolutely vital for making sure that the tension is correct, as well as following really nicely so we don't get any looping. But the tension's really important. Keep the correct tension on so it's not too loose, and this will close really nicely. So he's going to use 2 sutures to close the left atrium and meet that in the middle. He's going to first of all do the inferior side, and then he's going to start from superiorly. At the same time, he likes to give a dose of warm blood. So he's going to start getting the perfusionist to get ready a hot shot of warm blood only to get the heart beating, to get the left ventricle full. And you can see the heart is just starting to get some activity back. And this is also going to have a really important role in de-airing. So the assistant just placing this suture through the eyelet so we don't have to tie a knot, pulling the eyelet down. There you go. And now a over and over suture to get the top of the left atrium closed nicely, just as we're starting to fill with the cardioplegia, and which is a really nice way to de-air. So out comes the left atrial retractor, the third arm. As we do our last few stitches, the heart is filling with cardioplegia. Obviously, the clamp's still on, so it's safe as we get rid of as much blood as we can. And really amazingly, a lot of people have commented on how little air there is in the heart afterwards. It might be due to the fact that the heart isn't being manipulated very much, not moved around, or it might be this very gentle technique of giving a hot shot, filling up the heart nice and gently. But actually, there are very, very few bubbles after this surgery noted on the TOE, which is great. So we're nearly there. Last few sutures, left atrial retractors out now, and now we're getting that heart filled, and that's that last few stitches before we just get the assistant to tie the knot. In fact, just a little bit of de-airing just went there on purpose, and we're ready to suture the left atrium close with a knot. So there we go. So the assistant just uses the chipwood knot pusher to tie the knot. You can see the heart's beating already. And here, look at the cross clamp at the left. So flow down, cross clamps off, and the flow's back up, the vent's on, and we're done basically. So nice and hemostatic. Quick check for hemostasis, but it all looks brilliant. You've got a better view, of course. Cut this, and we're done with an operation. So we're just going to put a ventricular wire on. Super easy, of course. You've got great vision. Left atrial retractor just retracting there nicely. and just a single wire, just in case any heart block comes along. Ferris likes to put a bit of fibrillar over the top as well, just in case there's a tiny bit of oozing. But remember, look at this operation. All we've got is a left atrial incision, a cardioplegia cannula, and that is it for bleeding points, and the wire. So there's no sternum to bleed. The pericardium's not going to bleed. That's it, really. So bleeding is a lot less common in this robotic operation. So Ferris has now come back to the table. He's taken out the vent. He's just tying down those two pledgets, and we're pretty much finished. So there's the operation done. Let's undock the robots. And let's talk to Ferris about what he thought about the operation.
Thank you.
Do it ventilate or?
Don't ventilate, please.
Yes, a great job, Ferris. Awesome case. Tell us how'd that go then.
Yeah, thank you. So it went very well. When we started, of course, with the echocardiography, our echocardiographer as well as anesthesiologist have mentioned that the valve was thickened, the subvalvular apparatus were thickened as well, the cordi were shortened, and one of the commissures fused. So all these are indicative to more replacement than repair. Nevertheless, when we went on pump and opened the heart, we did find all the findings accurately. The valve was at least 35% thickened, and the subvalvular apparatus is with the cords are shortened. The papillary muscle are matted and fibrotic, as well as part of the scallops P1, P2, where it did look some congenital changes. So we did resect the anterior leaflet. We resect part of the posterior leaflet, kept part of P1 and P2 and P3 in place to prevent remodeling of LV. We inserted 17 plated stitch into the mitral annulus, and size 31-33 onyx mechanical mitral valve was inserted. We did ligate the left anterior appendage, and we performed the Maze procedure. So everything went well. However, it is funny, the patient is not obese yet. She's a bit wide, broad in the shoulder, and that's reflected on the heart. The heart was a bit deep. You could tell that all instruments were all inserted into the chest. Mobilization wasn't very optimal. Of course, she is 50 kg, she's short, so the thoracic cage is restricted, of course, in motion. Nevertheless, the surgery went very well, so I'm really happy. Aesthetically, she looks good. Echocardiography is perfect with LV and RV function, with seated mechanical prosthesis, normal gradients, competent ligation of the left appendage, and she's in sinus rhythm. We're gonna extubate the table, and we're gonna use the cryoablation as a nerve block for the thoracotomy, which is the working port. The other interesting thing, as you've seen here, our incision was 3 centimeter, and it could barely let the mechanical valve in, but yet it got in. So usually in repair we could go down to 2 centimeter, but in replacement is 3, and in bioprosthesis you could even need to go to 3.5 centimeter because of the struts. It's not easy to get into the working port. Other than that, it was a great surgery, I believe. Yeah.
I think you've done 520 cases, so they look like there's some amazing important tips there. So your ports are pulled out more for less clashing. You've got antegrade plegia in your femoral artery. I guess you guys have learned a lot over those 500 cases.
Correct. We always learn and improve. You know, it's progress and changes according to the need. So the tips that we know, especially that we have more than 50% of our patients with BMI above 35. So we use the long trocars for the chest, and that would minimize the collision between the arms. Number 2 is, yes, we do insert antegrade blood for perfusion for the lower limb. The reason why we noticed that, especially in our patient cohort, the femorals are small. So once we finished the surgery after bypass, we found that 2 things. We do add NIRS, near infrared spectrometry over the calf. We found that it decreases the oxygen saturation, and that affected reversibly on the lactate. It increases the lactate post-operatively when we don't have the antegrade perfusion cannula, and that delayed extubation. So when we started to put the antegrade lower limb cannula, it did improve the lactate, no more high lactate, and the extubation is, as you see, on table. So that's the second thing. The third thing, we do take our time when we, of course, examine the mitral valve. You have to examine the mitral leaflets, the annulus, the trigons, the commissures, the chordae, and the papillary muscle. So that's one. You need to take your time in examining the left atrial appendage if there is any thrombus in it. Number three is you need to look for PFO. Especially in our patients, we do have high rate and incidence of PFO for our patients. Finally, when you close the left atrium, we do take tips into whilst closing the left atrium, going into the side of the right and superior and inferior pulmonary veins, not to take deep bites. Make sure that the folds of the free edges are clear for you to take the bites, and not too deep, not too superficial either, has to be hemostatic and competent. So these are the things that we really take care of while closing.
Great job, amazing case, it's absolutely wonderful, and another to come. So
yes, other to come.
Get some coffee and let's do the next.
Absolutely. Thank you, Joe.
Thank you very much. Good job.
Thank you.